All right, we are live. Hello, everybody. Welcome to another edition of Premier Weekly Webinars. Hope you all are having a great Friday out there. I'm just going to check to see if I posted this to the right page real quick. Just a second here. All right, looks like we're good. So today's topic, we've had a couple webinars on knee pain already. One was on knee pain in general, anatomy, some common injuries. Another one was on knee replacement surgeries, kind of advice about what kind of treatments are good for that. And today is going to be knee meniscectomies, commonly referred to as knee scopes. So let's see here, a little bit about the clinic and myself. My name is Curtis Pachoka. I'm one of the physical therapists here at Premier. We are a privately owned physical therapy practice. We have two locations, one on Jacksonville Beach Boulevard and Hodges, and another one down in Ponte Vedra. We have specialties that include orthopedics, TMJ and facial pain, lymphedema, and running and golf programs. So the big topic for today is this question: to scope or not to scope? And what we mean by that is, should you get a meniscectomy surgery or not? What is the best advice out there? So you could go about this by asking maybe a local person, it could be a retired doctor, retired physical therapist, on what their recommendations are to get surgery or not. And you think that leads you to make the right decision, but it turns out without citing research, and that might be outdated research, but expert opinion is the lowest level of evidence. Because back when they were practicing, or someone who's not up to date with the current research might share with you the wrong advice, which maybe it was good at that time, but things have maybe changed. So I'm here with you today to share with you some of the latest evidence to help with you or your loved one's decision making. So a little bit about what we talked about on what's strong evidence. So here at the bottom here is expert opinion, something that's not been researched and someone's just giving their opinion on is not very good evidence. But strong evidence and even moderate evidence, you have these studies called, high quality randomized control studies. And you can even have systematic reviews, which is a review of a lot of evidence to determine if it's strong or not. So here's another rating system too. Um, and like we said, it's level one is high quality diagnostic studies. We're going to share with you today some randomized control trials and systematic reviews today. So, knee scope procedures such as meniscectomies are one of the most common orthopedic surgeries. The meniscus itself is a tissue. Um, it acts as like a cushion. So I have a knee anatomy model here. So your knee joint usually has space here. If you don't have a space, you have bone on bone, and that's very bad. You need knee replacement surgery usually if that's causing you a lot of trouble. But the meniscus tissue, not shown on this model, will actually be in this space, and it acts like a cushion, just like a seat cushion. It really can distribute weights in the knee, act as a shock absorber. Particularly, it's used when you're squatting, using stairs, maybe walking on uneven surfaces, any kind of weight bearing activity, going up hills, things like that. So that's the role of the meniscus. The general consensus is that removing meniscus tissue can lead to arthritis and decreased knee function. But don't take my word for it. So we're going to go into some evidence here. So this really new evidence, fresh off the press, 2020 randomized control trial, compared arthroscopic partial meniscectomies to a placebo surgery. It baffles me how they pulled this off. They got half of their patients doing a placebo surgery, which really mimicked. They still scoped the knee and went inside of it, and they simulated sounds of surgery and things like that to really get the full effects of the placebo. Um, they did everything but cut off a piece of the meniscus. So they did everything but the meniscectomy. So the patients were blinded to this. So they didn't know if they got the real surgery or just the placebo. And what they did was they followed them up afterwards. And the study resulted in the surgical group had slightly increased risk of knee arthritis. And there was no difference between the two groups in knee pain or function. So they both groups actually got better. Both groups still had rehab afterwards. They still received exercises and stretching, but there was actually no difference between the groups. One had surgery, one didn't. In fact, the one that did get surgery actually had more of a risk of arthritis after they got the surgery. So it kind of baffles my mind because I know a lot of people who've gotten meniscectomies. So should we get the surgery? Should we not? So I'm going to go over when you should still get the surgery and when maybe you should put it off. Um, so little quotes from some of the articles. Patients with degenerative tears are significantly more likely to develop radiographic osteoarthritis than those with an acute tear. And degenerative meniscus tears may be an early sign of knee osteoarthritis rather than a separate clinical problem that causes symptoms. So what that's basically going into is you have a meniscus injury, but what is it? Is it a traumatic meniscus tear or is it degenerative meniscus tear? So knowing this will actually help us decide on what do you need the surgery if you don't, because they're saying if you have a traumatic meniscus tear, and you know if you did this because it's you step in a pothole, you twist your knee, something of that nature, sports, you can have a traumatic injury that leads to a meniscus tear. Now that they're saying you need to do surgery on because you have a mechanical flap hanging up the tear, and the meniscus might have a piece hanging and it's catching and causing your knee to lock, so they need to remove that piece. Versus degenerative meniscus tear, they're now thinking it's not very much a problem with the meniscus at all. It's more of an early sign of knee um, osteoarthritis, but it's before you get the osteoarthritis. So the meniscus, since it's a cushion in between your cartilage, it's only a sign that that's wearing away versus an injury to your meniscus. So the surgery, the meniscectomy to remove more meniscus doesn't actually make sense in that scenario because if you're uh, deteriorating all your meniscus. And so you have meniscus pain. Removing that meniscus is only going to lead to faster osteoarthritis. And that's what the research is showing. So meniscectomies can be really useful if you have a traumatic meniscus tear, lead you to really good function and return to less pain, return to activities. But it's showing that with degenerative meniscus tears, it's not that it really hurts you too much. It really just is not effective compared to just rehab alone. There wasn't really a significant difference between the two groups in that study, the ones that didn't get the surgery and the ones that did. So, just to summarize everything, therefore, getting a meniscectomy for degenerative tears may not be effective and could lead to early development of knee osteoarthritis. So, before considering going under the knife, ask yourself: is it worth the surgery? You know, there's still risks with surgery if the evidence is not supporting that decision. So, here at Premier, we're always looking at ways, looking at the evidence, and to share it with you to help you make the right decision because it's your decision, it's your health. We just want you to make the correct decision, a decision that we would make ourselves or we would tell a family member to make. And we just want to publicly make everyone aware about what's the best evidence to help you with that decision. So, like we said, both groups actually got better. So if you have degenerative meniscus and you don't, you feel like you might fit that category. Um, and if you agree with this evidence and you feel like the surgery isn't worth it, then you can still get better because both groups got better with the rehab after the surgery. So what we can do is that rehab portion for you. So we do everyone, it's a custom program. Everyone is different. So it's individualized. So we look at your strength, your range of motion, and we assess some other things too, your mobility. We can feel how well your knee moves. Um, and then we look at everything else. Your ankle and your hip are also connected to your knee. So we basically do a thorough evaluation, make a custom plan for you, and talk about what treatments could help you and your pain. In this case, of the knee pain, we talk about what things can help you and your knee pain. Um, so you got a couple options, decisions to be made. If you have knee pain and you have evidence that it could be degenerative meniscus, you can come in for an evaluation. The second option is to schedule some telehealth consultation, basically, where we can just talk over a webcam or the phone, and then we can see what are the best options for you. If you're not comfortable with coming in, we can at least talk to you and get a good idea of what's going on. Or you can start with some of the education I provided. You can look up some exercises at the gym and start performing those and see if it gets better. Um, But it's pretty short webinar for today. That pretty much sums it up. I'm gonna look at any other comments in this section. I see Vicky posted this. Glad you have this. Hubby needs the info. Yep. And if you missed anything, this will be on our YouTube channel for those who weren't able to tune in for the webinar or the full webinar. Other than that, we are done for today. It's Friday. It's feeling great outside. It's feeling like fall. It's going to be 70 degrees here in North Florida for the next couple days, so that's going to be nice. Football's back, so things are feeling like fall. It's getting darker earlier. Uh, is the first week that I really felt like, okay, summer's over, time for fall. Other than that, thanks for tuning in. Appreciate it, and we are logging out.